Hello, everybody. Today, for the IU Bioethics Grand Rounds, I get to introduce myself. See, it's a special treat to me. And thank you for being here. Thank you for people being online. I don't see the number, but there you go. So we have a few people online. Thank you for all being here. We do have CME credit for today's activity. Text that number to that number, and you'll get an hour of CME credit. We'll come back to that slide later. I have to show the disclosure. That's our accreditation statement. I have no financial conflicts. Okay, and as a official activity of the IU Center for Bioethics, I get to advertise our many wonderful events, both today and coming up. We have a treats seminar on December 5th. That's Translational Research Ethics, led by the wonderful Andrew Brightman on students as subjects. We have a few grand rounds scheduled for the spring term. In February, we have Lauren Nephew on liver transplantation. In March, we have Megan Haley from Stanford, who will be talking about genomics and rare diseases. In April, we have our Silvers annual lecture on Holocaust, bioethics, and genocide, and that'll be presented by Amber Comer. In May, we have Paul Hann from the NCI coming in to speak about clinical uncertainty, and he'll be doing medical grand rounds the next day. Finally, we do have some more treats seminars to schedule, which we'll announce soon. I want to just say a couple words, again, because I am the center director, and this is a wonderful activity of the center. I'm proud of our center for now having a Grand Rounds seminar series that's well attended, wonderful speakers, and I think a contribution to this community. And so the Center for Bioethics is strong. I am thrilled to be a part of it and to have the chance to collaborate with many of these wonderful people. I am, as poor Nick Oliver, our program manager, knows, I'm a little obsessed with our events page, which you can go to anytime, including you see today's event on the upper left there, but also non-IU events. So things online you might be interested in. A lot of us in bioethics and the working world of bioethics are on these listservs and things. So we always hear about these talks, but we wanted the rest of the community to get a chance too. And here are the wonderful people of the Center for Bioethics. Look at those smiling faces. We caught them all on good days when they were smiling. Sometimes we're all frowning. We all work hard, but we look more tired than in those pictures. But it's a wonderful group to work with, and I'm honored to lead them to the degree to which I do. So today I'm going to talk about evaluating, I'm Peter Schwartz. I'm the director for the Center for Bioethics. I'm also a professor of medicine and professor of bioethics at the med school and professor of philosophy at IU Indianapolis. So that's who I am. The title we announced was Evaluating Patient Decisions, How, When, and Why. And in my mind, I have my little personal title, which is What is Decision Quality? And why, I guess I should have put here too, why does it matter? Here's a sketch, a little graphical sketch of the talk I'll present today, starting with bioethics, of course, and autonomy and consent, such central concepts for the field of bioethics. That leads to concepts like shared decision-making and patient-centered care, which have been widely adopted in medicine. There are then fields that study the progress and the distribution and the provision of medical decision-making and health communication in fields with those names and specialized journals. Once you are doing science and you're trying to measure these concepts and whether these things are going on, you need measures of something I'll call just roughly decision quality. And my warning today is these measures have real problems. And I want us to think about what decision quality is, in part, in light of how hard it is to measure it. Doesn't mean it's a useless concept, but it means our understanding of it may need to shift. And I will describe and try to engage you in a conversation about the goals of bioethics in light of these sort of limitations on what we can measure. I've written about this with Greg Sachs. I want to thank Greg for our conversations about this and for participating in this paper with me. That was about 1.5 years ago in the Hastings Center. We're proud of that work. And in this talk, I'll try to bring you up to speed with some of our thoughts in that paper and maybe engage you in a conversation about next steps. So How do we think about this field? Well, how do we think about this issue? I'll date the beginning of modern bioethics to the 1960s as a civil rights and advocacy movement that was anti-paternalism in medicine and pro-patient rights. We can all argue over when bioethics started. Of course, Hippocrates is a reasonable place in the West, but for the modern bioethics movement, it's appropriate perhaps to put it in the 1960s. Then we should think, then that led to very clear articulations of the goals of respect for persons and patients and the autonomy of patients and persons. And then the concept of informed consent, like I mentioned, where we agree and have accepted in a way that probably was not accepted before the 1960s and or 1970s, that competent patients can reject or choose any medical intervention, even when it's potentially life-saving. And I have the Jay Katz book cover up here. It's a wonderful book if you want a good read. My students often have to read it, and he has a wonderful statement of it, including he also had made the next step by the 1980s when he published that book to share decision-making from simply having the ability to approve or deny a proposal from your doctor or other provider to a shared process of decision-making where you're there together choosing the next step in the patient's care. And here's a title by Mike Barry and a co-author from New England Journal about how important that is. The model of shared decision-making is complex, and we could spend the whole hour talking about that. Here's one model to get your head around. The clinician brings technical understanding, right? She knows a lot of medical facts. She knows science. She knows about the medical research. She can't convey all that information, but she can convey key information about the possible diagnoses involved and a lay understanding of what that means, the treatment options, and the risks and benefits of each. In this conversation, then the patient brings values and preferences, right? In discussion with the provider, they consider the options and risks and benefits of each. They evaluate the chance of good and bad outcomes and how good or bad those would be, and they choose one option as optimal. The sort of idea is the clinician brings the facts, the patient brings the values, they converse and choose something together. And what are the limits of it? Well, there are many. Challenges, limits, we sort of know it's not going on in the way we might ideally hope. Limits in patient understanding and misunderstanding. Limited time for discussion, limited ability of clinicians to talk and to listen, and limited inclination in many cases. The complexity is a tremendous challenge for doing shared decision-making. It's why we do it, but it's also a tremendous challenge to doing it. The widespread difficulty in handling probabilities. Every medical decision is about chances in the future and trying to affect those, and people have trouble thinking about that. We say patients have trouble, but yes, doctors and other providers do too. Clinicians don't really understand what their patients value. A lot of things point that out. Patients are reluctant to speak up for themselves, to challenge recommendations. And often patients in the situation will say, just decide for me. Looks like the death of shared decision-making when a patient would do that. On the other hand, some have argued that it's not the death of it. Maybe we should accept and endorse a model where a patient could just say, I don't want to be bothered, just choose for me, take care of me. Would that be shared decision-making? These are all challenges, I'm going to say. Now, I'm going to take a little pause here. I almost cut these slides out this morning, in fact, but I'm going to keep them. It's a little bit of a detour, but I think we have time because the talk comes in about 35 minutes, so I think we have time. Which is that when you think about decisions, you think about the kind of decisions people are making. Of course, there's an infinite number. I'm, of course, not today talking about some of the really hard decisions. Those of you who come to the Fairbanks Center for Medical Ethics call this morning, we had faced medical decisions with competency questions and, real life and death questions. I guess my concepts, I think some of these things I'm going to talk about today would apply there, but maybe the decisions we'll think about are a little simpler. But among relatively more simple decisions, consider recommended choices where there's a strong recommendation towards one option. So antibiotics for pneumonia, mammogram for a 60-year-old woman, COVID. Oh, yeah, I'll take that one off. Okay, cool. COVID vaccine, right? Strong medical advice to do this thing. Then there's preference-sensitive choices, cases where even doctors and health professionals don't really know what's the best choice and say, you have to decide, patient. You decide what fits better with your life. We call these preference-sensitive choices. This might be mammograms in an older woman or perhaps a younger woman like 40, mastectomy after a BRCA mutation perhaps, versus other ways of monitoring, and anticoagulation in certain cases of atrial fibrillation. Like, how do you balance the goals, the possible benefits, the possible risks? We say it's up to you. We can't tell you what the right thing is. Some cases we think we can, antibiotics, quitting smoking. In other cases, we can't. In fact, some would say there's a whole range here, 2 dimensions, maybe more, of like, as the treatment risk goes up and the medical uncertainty of what we think you should do goes up, more and more importance for 2 people to sit together and make a shared decision about it. So a little bit about the realm of decisions, though, of course, this just scratches the surface. How are we going to improve shared decision-making and decision-making in medicine? There are all kinds of things tried, right? Do we train providers in communicating and conversing with patients? Do we modify the clinical experience to have people actually have more time and maybe more, encouragement to actually talk? Do we provide patients with information? We call these decision aids, which explain options. They help the patients decide what they want, and they help them talk to their providers. Those are often designed around preference-sensitive cases where we really feel the patient and the provider have to talk to find out what the patient wants. There have been hundreds of trials of these randomized controlled trials. The latest review, which I just found while preparing for this talk, do you know there's a new one? 2024, Stacy came out with her newest one. 200 randomized trials. Stacy's her last name. 100,000 participants, whole range of clinical scenarios used by patients independently and sometimes with their providers. So it's a whole field of work funded by the NIH and other institutions. Do they improve decision-making? Are they making a dent, the decision aids or the other interventions? Well, how would we know? Well, we're going to do randomized trials, like I mentioned in the Cochrane review, right? Randomized trial. By the way, I forgot to say something at the beginning. I'm going to take a little break here. People who are online, and there are a bunch of you, I guess, I don't see exactly the number, but feel free to type questions in the question box. And at the end, we're going to stop and we're going to open up so everybody's mic is open. And Nick may call on people in order of questioning, or maybe he'll pick some questions, and then everybody else is welcome to join in too. So just so you know, if you're sitting there bored online, that you can talk. We might take our first couple questions from the room, where people are, just to let you know, online, people are noshing on donuts and coffee. So sorry you're missing out. I was going to hold a donut up at the beginning. I decided not to because, okay, so how are we going to do this? Randomized trials. So randomized trials compare, for example, some intervention like a decision aid to usual care, or they might compare decision aids. This is actually the work that my team does. These are 2 articles we published in the last few years where we did randomized trials of decision aids that were designed in different ways. One had numbers, one didn't. One gave population information, one gave personal level information, one included a nudge, one didn't. So this is kind of work we do and that a lot of people do to try to figure out how best to improve decision-making in the clinic. So remember, because these are preference-sensitive decisions in many cases, there's not a single medically preferred option. So we can't just measure, oh, did we get people to do this thing? Like if you're studying smoking cessation, you just want people to quit smoking. You almost don't care why. In these cases, that's not the situation. We want people to make a choice that's good for them. How do we measure that? How do we know whether we've made a medically informed or a good choice, a choice with good decision quality? We want to improve the quality of the decision made. We want to improve the quality of the decision-making process. We want to know whether it was shared. How are we going to measure these things? There have been hundreds of measures developed in this area. Not to scare you, we'll go over each one. No, in the 30 minutes we have, about 25 minutes left, I think, we'll go over 3 groups that I'll tell you about. So what are these measures trying to measure? What are they actually measuring? And again, getting back to that first question, if we're trying to measure the thing called decision quality, what is that? Okay, the 3 approaches. I'll go over, I'm check my time. It is now 12:13. I'm exactly on time. Very good. I'm gonna take it. That allows me to take a drink of water. It always lets me go over and grab a cup of coffee, which I'll do during the question. Okay, 3 approaches. It's gonna go by quick. I'm happy to go back during the discussion. They're pretty straightforward to my mind, but I know they're new to some people watching, so that's okay. My research team is here too, and it's not new to them. They're very familiar with these measures. Okay. Subjective approaches. They ask the patient's feelings or opinions about the decision or the decision-making process, sometimes looking backwards, often looking backwards. I'll talk about that one first. The most famous one is the decisional conflict scale. It's been used in hundreds of studies in more than 10 languages. A lower score is the desired, and that means there's lower decisional conflict. You've eliminated conflict, which means that's been associated in studies with making decisions more quickly, being more satisfied with the care they get, and having less regret. In the scale itself, it's 16 questions in the full form. There are shorter forms like 10, and there's one which is just 4 questions. They answer each question on a Likert scale in the full form, agreeing to disagreeing with each statement. And there are subscales that can be looked at about whether they're informed, whether they feel that they have clarity about their values, whether they feel supported, and whether they have uncertainty, and whether they feel effective in implementing their decision. Here are some examples of the kind of statements they agree or disagree with. The informed subscale says, I know which options are available to me. Agree to disagree. I know the benefits of each option. Again, I know the risks and side effects of each option. In the values clarity subscale, one of the statements is, I know which benefits matter most to me. I'm clear about which risks and side effects matter most to me. Support. I have enough support from others to make a choice. I'm choosing without pressure. Uncertainty subscale, I'm clear about the best choice for me, or I feel sure about what to choose. Now, look, these are important concepts. It's nice when people agree with them. What kind of problems am I going to raise for this kind of approach? Well, here you go. Let's look at the informed subscale, where the patient asserts that they know which options are available to them. They know the benefits of each option. They know the risks and side effects of each option. The problem is that when patients feel good, let's start there, they think they do know, they may not, right? They say they know, but they don't. That's all very well and good. It's a nice feeling, but it doesn't necessarily reflect very good decision-making if they don't actually know their options. They may feel their doctor must have told me everything. The things they told me, I understood, but maybe the doctor didn't tell them everything. Second, of course, is the opposite, where people feel like, I don't think I know everything, but they actually do. They're reaching for straws. They're reaching for more, but they actually do know a lot. So that's a limitation on asking them their feelings. Values clarity or uncertainty. Are they clear about what benefits matter, what risks and side effects matter, what's their best choice? They say they do feel good about that, or they say they don't. And remember, their score is worse when they say they don't feel good about that. They don't know which benefits matter. They don't know which risks. They're confused. Their decisional conflict is higher. That's not a good thing. That's a sign of a bad decision. Or is it? Or is it the sign of a bad decision? Isn't that the sign of a good decision sometimes, right? There are hard choices. Saying I don't know what to do, I don't really know how to think through this, doesn't mean that they've made a bad choice. Maybe it means they're actually struggling with a hard choice. And it can be good, it can be part of good decision-making. In fact, it could be an improvement in decision-making to be unclear how to balance the risks and benefits and what to do. Here's another quick example from the subjective area, the Likert scale. Again, sorry, decision regret scale. It again uses a Likert type answers. It's asked after the decision. They're asked to agree or disagree with, it was the right decision, I regret the choice I made, I would go for the same choice if I had to do it again, etc. Measures of regret. So is regret a good thing to measure? Again, I can see the attraction, but here are some problems, right? Patients may make a good decision. They may have chosen very well, but they may regret it. Maybe it had a bad outcome, unfortunately, even though it was the best choice. Or maybe it was just incredibly unpleasant. They look back and say, oh, I wish I had never gotten involved in that. Or they may make a poor decision and fail to regret it. I'd say this one's even more dangerous, right? That the regret scale actually has this problem that people feel pretty good looking back at their decisions, even if they were maybe ones we would really criticize, right? Maybe it worked out fine. They didn't know any of their options. They didn't know much about them. They just did what they felt like or something, or they were talked into something that they would never have chosen if they knew more. But it worked out okay. So in some sense, pretty bad decision. Other sense, I'm glad they did well. But it's not necessarily a very sensitive measure of whether the decision or the decision-making process was good or bad. Observational approach is the second approach. You'll see it's very different. The idea is that somebody looks and rates the conversation between the provider and the patient. The Elements of Informed Decision-Making Scale by Connors Braddock, the Observing Patient Involvement in Decision-Making, the Option Scales by Elwin. We'll talk about option 5, it's called, where two individuals listen to a recording of a medical visit and rate 5 areas that are covered by the provider. The 5 areas are whether the provider drew attention to alternative treatment or management options, whether they reaffirm their support for the patient, whatever they choose, giving information and checking understanding, asking basically what the patient wants, and trying to include those preferences in the choice. Each area is scored, right? 0 means they didn't try at all in that area. 1 means there was a little bit. 2 means some quick comments. 3 was a longer conversation. 4 was a really long, deep exploration of that topic. And you can get 0 to 4 points for each of 5 areas for a score from 0 to 20. The advantage of this is that it's objective. It's an objective observation to look at what the conversation was like, not just what the patient remembered about what they felt about what they heard. The problem is maybe a problem you were thinking of when I was talking about those quick decisions before. Sometimes a good decision might have a quick discussion, right? Sometimes a quick discussion doesn't go over everything, at least on one occasion, might be an okay discussion. Take this example. So, if a woman considering mammograms, let's take the preference-sensitive choice of a maybe 80-year-old woman considering continuing with mammograms versus not. Again, mammograms are not recommended beyond age 75. They're offered just because the data for benefit is limited. The areas, of course, are these 5 areas, and the scores are there. If you think about a conversation in a provider and a patient who know each other, maybe it's the annual meeting, maybe she's already decided to do mammograms between ages 75 and 80. So she's been already moving into the elderly age where she's continuing mammograms. It's clear how she feels. The conversation could be pretty quick, right? If people who know each other and there's an established clinical relationship, well, it looks like maybe on these areas you might get 1s or 2s, right? Now, you might say, Peter, you're being too kind. That discussion has to be hit every year in these detailed, ways that the option 5 rewards. I don't know. I mean, you really have to think about whether that's a good use of time, given that they do understand each other. She knows the doctor's going to offer it. She knows what she wants to do. She knows what she wants to do. They move on. You might say, Peter, okay, fine, Peter. Look at more decisions. Look at all those meetings they've been having and try to rate through all of those how much they've talked about mammograms. Well, I wish, right? That's exactly what these measures are not able to do. Is something like recording all the visits between a provider and a patient and rating those. This is just the thing that's used in research is one meeting usually, and this is the limitation. One of the many. One of the significant ones. Down to my last measure. So again, I'm not saying these are useless. I'm just highlighting their limitations. In fact, we use them, so they can't be useless. My research uses them. Concordance. The informed concordance, the values concordance approach, which is a very popular, influential one, where what we're trying to measure is whether the patient's informed in their knowledge test, not just asking if they feel informed, but measuring whether they're informed, and whether what they got, the care they got, matches what they want, what matches their values, the goal of a preference-sensitive choice. Some examples are the multidimensional measure of informed consent by Marteau and the decision quality interest by Sapuka. So just the people in this room certainly know about this, maybe not everybody online, but the idea of concordance can be a little hard to get your head around. I'll take a minute to review it. The idea is that people have values that make different sorts of care appropriate for them. So some people have values that are appropriate, make aggressive care more appropriate, or certain kinds of aggressive care. Some have values that favor other kinds of care. That's one of the ideas behind this. Let's go back to the mammograms again. So some people have values that would support continuing with mammograms into an older age or starting younger. And some people have values that are against that. And so the idea is in medical decision-making to figure out which one you are, right? To let you have a choice of deciding what your values are and how you want to apply them to this decision. That would be the ideal. And concordance is trying to capture that. Have we given you what fits your values? So again, maybe I'll belabor this, but if your values support getting mammograms, you should get a mammogram. If your values support not getting mammograms, you don't want any more trouble, the risk is not, the benefit's not high enough, then you should not get mammograms. Like, it's sort of a basic idea. Discordant care would be the opposite, right? Your values are for mammograms, but nobody's giving them to you, or vice versa. You really don't want them. That doesn't fit with what you want out of your life, but somehow you're getting them. Decision only counts as a good one if the patient had adequate knowledge, they passed the knowledge test, and they got value concordant care. The advantages are, I hope, pretty clear. It's an objective knowledge test rather than some kind of thing about how they feel. So we know whether they're informed. And it assesses whether the treatment was appropriate for the patient, not just looking at the process like we did an option where we're trying to record the conversation, see whether it was good. Now we're actually looking at the outcome. Sometimes people writing about this say, well, those first two approaches are really about the process, and this is about the decision. I don't know if it's that clear. Problems. I'm going to raise problems. Okay. First, what is adequate knowledge? So an enormous amount of information is relevant to any medical decision. Of course, people are not going to understand all of it, but we have to set a line. And everybody in this room, look around the room, we've written knowledge tests, so we know how hard it is. What goes on the knowledge test and what kind of question? What do people have to pass in order to be counted as knowledgeable? It may vary on situations and patients. Josh Rager is here, and me have written a paper with others on our group, Karen, about, what kind of knowledge has been asked on these knowledge tests around the colon cancer screening area that we work in. And the answer is all kinds of knowledge questions. I mean, they are amazingly varied what people decide is essential. That's one problem, maybe, a problem, not the end of the world. How can we determine whether a person's values are consistent with the treatment they receive? And does it even make sense to try? That's a depressing question. Let me ask it here. So consider the mammogram case again, right? What are the values in favor of continuing with your mammograms? Extending life, avoiding dying of breast cancer, avoiding getting advanced breast cancer. The values opposed, of course, are avoiding discomfort of mammograms, avoiding anxiety of undergoing the test and awaiting a result, avoiding possibly unnecessary treatment, because you'll find cancers that get treated that never would have caused a problem. So I think everybody in this room holds all of those values, right? Whether you're a mammogram person or you're a colon cancer person, right? Like colon cancer screening person, these are the values you've got to balance. Everybody's got the values. It's a matter of how much do you weight them? How do you balance them? And that's a pretty hard thing to calculate. In fact, you've got to weight values, which is a hard thing to do personally, and certainly as a researcher. In fact, and this is an interesting fact, psychologists argue the idea that we have these values that lead us to make decisions is maybe misleading. So we sort of imagine it this way, right? I've got my values. I walk into my doctor's office, just like in that original model, right? And I think, here are my values. Here's my situation. I'm going to apply my values. Well, right, psychologists argue it's actually the other way. Right? Often you don't know your values because you've got them all and they're all a jumble and you don't know how to weight them. And in fact, it's not till you make the decision that you actually prioritize and rank order and combine those values. You actually, there's a fact of how your values should make you go. It's more like the other way. What you decide will help you figure out your values. And there was no fact about them before. Anyway, philosophical point, which is why I get excited. And somebody's nodding, Elizabeth's nodding vigorously, which I like. That's what I did too when I first heard that. I thought, that's the coolest fact I've read this week, or this month, or maybe this year. Okay, so we actually, speaking of discordance and the problems of measuring it, in our studies, we actually don't try to figure that out about values. We actually ask people what they want. We see if they're informed, we ask them what they want, and then we see if they got that. That's a poor man's way of trying to do this. Did people get what they want? We can't sort of calculate it from their values. Let's just ask them what they want. That's what a lot of people in this field do. So in the study, though, we looked at the people who said they wanted one type of colon cancer screening, but they got the other. And in our study, looking forward, when Karen and I put this together in the beginning, we asked an additional question, which said, why, wait, is that here? Oh, no. Right. We asked them, why'd you do that? Why'd you get that test? And if they had switched from beginning to what they got, we said, why'd you switch? What's up? And so we looked back at these in this paper that Josh, Karen, and I wrote. Here were the 6 areas that it looked like their reasons fell into. Sometimes they said, yeah, I really wanted a fit. It's a stool test, but I got a colonoscopy because, that stool test isn't really that good. I sort of thought more about that. Or I switched from the colonoscopy to the easier stool test because that prep for that big test just put me off. I decided to switch. Or they switched because of the benefits of the alternative test. Like, well, I was going to get that stool test, but I wanted the best test. I wanted a colonoscopy that's so much more accurate. Or I was going to get colonoscopy, but I just couldn't go through with it, so I got a fit test. Sounds like somebody I know. Okay, so cost. Maybe they said it was too expensive. They found out about cost, right? Maybe they had a discussion with families or friends. Maybe they talked to that provider who made a recommendation. Maybe some health issue arose where they, for example, switched because they had some rectal bleeding. When we look back at them, we try to figure out which of these reasons are bad reasons. By the way, the reviewers of this journal hated this, that we kept saying this looks like they were pressured into it. You don't know if they're, right? If they made a choice, they changed their mind, that's actually good decision-making. A decision doesn't happen at a single moment, right? Maybe on 6 months earlier, they thought they wanted one, they switched. That's actually not, this discordance between what they said they wanted and what they eventually got is not a problem. It looks like discordance. It gets a bad score on the informed concordance scale, but it's not really bad. Some of these discussions with families and friends, and those were the ones that were suspect, right? Where it said, my doctor just said he wouldn't give me a fit test. I had to get a colonoscopy. That sounds like what we were looking for, what we were afraid of in discordance, but it wasn't all of the cases at all. So at the very least, we have to look into the reasons for discordance. Discordant care may not always indicate a poor decision or a poor decision making. Okay, that's it for my talking about measures. Those of you who've been struggling through a lot of technical stuff there, I hope it wasn't too technical, but now some conclusions. There were 3 that I'm going to highlight. They're the same 3 as in our paper. No measure, and I'm going to say no combination of my measures, but look at each measure individually, can reliably indicate the overall quality of a decision or a decision-making process. So each measure, as we saw, has something to be said for it. They're looking at important features. Better scores on one measure doesn't mean that it was a better decision. You could have a great score on the decisional conflict scale, but it could be uninformed and truly discordant care, the bad kind. Of course, even within one approach, let's say the subjective approach, there are multiple different scales and they may have different answers. So even if you say, well, I'm just looking at subjective feelings, well, there's the regret scale, which may give you a great score, and the decisional conflict scale, which gives you a poor score. This is not special to looking at the quality of decision-making. How do we measure quality of healthcare, say, provided by a clinic or a healthcare system? You could look at the experience, how do patients feel good about their experience at clinic? Did they feel like the provider listened to them? You could look at process, calls are answered on time or not. You could look at outcomes. You could look at, whether patients in that clinic have good blood pressure control or heart attacks or not. No one of these will reflect the full quality of the clinic. You need probably all of them and maybe more. Quality of life. Actually, in medicine and economics, medical economics, we measure quality of life a lot. And of course, there are an infinite number of ways to do that. It'd be an easier argument even to make about that. You can measure all kinds of different things, and researchers do. Those of us who teach know that when you grade students, you're not really grading the quality of them, maybe the quality of their thinking, the quality of their understanding. There are a million ways to do that. They aren't the same. Some students will do better on one way and not the other. So we know in the heart of hearts, there's no sort of single fact of the quality of thinking or understanding for a specific student. So that leads to a somewhat skeptical philosophical conclusion for those of you who like to think about whether it's a thing. Are we measuring a thing called quality? It looks like maybe not. I always, when I think of that, go back to one of my favorite books, a novel called Zen and the Art of Motorcycle Maintenance. Even if you hate this talk and you do not want to ever think about it again, it's a great book, a bestseller from the 70s. Richard Gunderman taught me that also it's the book that had the most rejections before being published and then became a bestseller. 162 rejections. So those of you who have papers that you can't get published, don't worry. You could be like Robert Pirsig and write one of the most important books of the 70s. In it, he talks about the struggle of trying to measure quality and how that upends in his mind much of the philosophical understanding of the world that he associates with the classical thinkers, but also with all of the Western world. This question about how to measure things that are hard to measure applies in, of course, areas outside of quality. Consider psychological states, such as aggression, anxiety, or depression, right? You can choose a single measure. Well, let's just say it's, how do you measure aggression? Well, it depends how you measure it, right? There are many different ways to measure aggression, many different features of aggression you might measure. Same for depression. You can choose a single measure. You can combine measures for a specific purpose. So you certainly can use measures. They give you something. The idea is a signal magnitude there lurking is somehow, I would say we probably have to make sure we're not falling in for. Maybe you listening are saying, Peter, I never fell for that. That was just you and your philosophical mind. Okay. If there is something there, it's vague. It's not precise. It's our second conclusion. My second conclusion, it probably makes more sense to categorize the quality of a decision broadly as good, satisfactory, or poor, for instance, not as having a number. The measures may be relevant for trying to come up with that categorization, and good scores on all measures, that's a good thing, right? That's certainly going to point towards the good category. A bad score, I don't know what it means as well, right? Maybe it means the decision was poor. Maybe it doesn't. Maybe a bad score on decisional quality actually is not a bad thing. Maybe the decisional process was actually not bad. A bad score on option 5 may indicate an appropriately abbreviated conversation. Any final evaluation going from those measures to a final evaluation, of course, is going to call on judgment and qualitative judgment that is not a quantitative measure or a measure of combining a matter of combining these measures in some a clear way, algorithm. It'll involve judgments about autonomy, deliberation, rationality, and preference. Third and final conclusion, researchers in this area and bioethicists, certainly who are committed to improving quality of decisions, should focus on addressing and identifying and addressing areas of problems. That's actually an important thing not to forget. If you use those measures, it's really most helpful for finding problems that you might be able to address. So bad scores could point out something important. My motto here is identify and solve problems with decision-making rather than moving the needle on decision quality measures. The mistake that I'm trying to head people off from is thinking that, if these are the bad features of some of the worst cases, we should use them to sort of build a scale that somehow there's a decision quality that we're trying to change up or down. Better to find the problems and fix them. Here's the analogy. I'll finish with this. So we often see injustice in the world, and we make those judgments based on things like oppression and exploitation and discrimination in those settings. We actually then decide that those kinds of problems are in place by looking at maybe measures, right? Living measures, resource distribution, ethnic or racial representation. Those might be measures we use to identify these bad features. But of course, even though we're looking at these measures and we're deciding when there's injustice present, we don't try to create a scale of like justice level, right? Maybe the Justice League has to do that. No, justice level. We don't like say, oh, well, this is justice level 52 and it's got to move up to justice level 55. It's that you want to find the areas of injustice. And the final punchline is that actually working to improve decision quality in medicine and weeding out those bad cases is actually not that, it's not really an analogy, right? It's actually a case of injustice. Right? So when a patient is not treated appropriately, when a decision is made without their appropriate involvement or understanding, that's injustice, right? That's unjust care. That's unethical care. And that's why we focus on it. That's why the field of bioethics started here, and the modern field to try to improve and address these problems. Improving medical decisions is part of bioethics. Quantitative measures, of course, are important, but the measures are mostly just tools to identify problems and promising solutions. And we must always avoid any danger of thinking we know what decision quality is and we can somehow, incrementally change it. Right. Oh, right. Well, I'll finish with a couple more things. Patients certainly have to have the option of learning and participating, but they, of course, may not want to, as Carl Schneider pointed out. I will say this leads into a discussion of nudges. I decided not to put a whole section of the talk on that. I'm actually hitting my time exactly of 12:38, so I'll finish here. But there's all kinds of things you can talk about. People talk about the ethics of nudging patients in different directions. It probably comes back to some of these thoughts about what is a good and a bad decision the patients might make. Thanks to the man, I decided not to try to list all the people I've bored with my thoughts on this topic. Of course, all my mentors at the med school and before, all my research team, as we try to actually puzzle through the kind of research we do to actually measure and improve decision making. And that is it. Let me go back and give you the CME code in case you are eager to send that in. And we can also now talk. So first of all, in the room, any questions? I've got to show you online this incredible thing which is going on in this room. This is a block. It has the IU thing on it. And it is a block you can talk into. So now when people want to talk, we can just throw them. Sam, walk up. How amazing is that? This is brilliant. We used to have to run around. I used to do, whenever I taught, I would run around with a microphone like the Olympic torch. That was always my joke. Was like, now I can't do that. Okay. Questions in the room, and then Nick will take care of asking questions from do we have some online questions?
One so far.
One so far. First in the room, and then the one online. In the room gets priority because they came for donuts, which I'm going to go get. So if you don't see me here.
Can you cut it?
I'll just let the hold the phone.
Yeah, this is great. Thank you, Dr. Schwartz. This was fascinating. I can't tell if this is super loud or. Okay. Well, it picks you up too. So I thought this was really interesting. I'm very fascinated by the question of how you determine whether, like, what the quality is of the decision practically. And I was reminded of some of your work on informed consent in biobanking and how it drew on Beskow's kind of expert consensus model on determining what is and isn't a good decision or a good outcome. What's adequate knowledge, which was one of your questions. And it really is, I think this is like the constitutive, the kind of the constitutive problem is determining what's adequate knowledge for all of this. And I was wondering, you're, I think, getting kind of close to this. You probably didn't say it because it's a bad idea, but I was wondering kind of from a pragmatic approach, if there was a way of taking the outcomes if from the patient's perspective. So the patient looks at the outcome, says whether the outcome aligned with their values or not, and then seeing what information was necessary to get that patient to that outcome, irrespective of whether the experts thought that was a good outcome and irrespective of whether the experts would have thought that those aspects of knowledge or those pieces of information were relevant to the decision.
Yeah, no, it's a good set of questions. I don't know where to start. We could definitely take another hour. So I'll start now. No. The Beskow case he's talking about is actually a fascinating case if you're interested in quality of decision making. The Beskow group at Vanderbilt put together an adequate knowledge test for patients who were participating in biobanks. 10 questions, I think. 11 maybe. I think it was 11. It might have been 21 and we cut it down to 11. Anyway, it's a certain number. They really decided what do people really need to know to make an informed choice. Kind of the discordant care thing, the values concordance measure. And then they tried it out and patients didn't pass. They'd been given great information and they did horribly. And Beskow went back, to her credit, and her colleagues, and they, Beckwith, no, that wasn't Beckwith, who was their co-author? And they went back and they asked their experts who had made it and their patients and, you know, lay people who had made it and said, what should we do with these people who didn't know? And they said, half of them said, they shouldn't be part of the biobank. They didn't know enough. And the other half said, you know what? They chose not to learn it. They had the information in front of them. We know we gave, they chose to participate based on trust maybe. And they basically were stuck. Like they basically didn't know what to do. So it's a fascinating question about what to do with an adequate knowledge test in that setting. Getting back to Carl Schneider, again, may he rest in peace. He's been gone a year and a half now. And I really respect what he brought up here. What are we to do with people who choose not to learn? Should we say it was a poor decision? They chose to make a poor decision? Or did they choose to make a perfectly good decision, which was their choice? How much should a person learn? That's up to them. We've done some work. TJ Kasperbauer and I, and now Tom and I have done work. And we ran a public deliberation with, as you said, lay people to ask them, what do you need to know? And the answer's all over the place, but they get hung up on the same problem we do, which is it right to require them to know anything? Because a person might be given information and say, doc, tell me what I should do. Or they might say, IU Biobank, Indiana Biobank, I want to help. I don't even need to know any of this stuff. And as long as the provider or the researcher are actually acting in a trustworthy way and protecting the participant or the patient and serving their interest in the case of healthcare, maybe it's good enough. Maybe the whole idea of that being a bad decision is wrong. There's still bad decisions, which are the badness of them is based on lack of understanding. But a person who chooses not to learn, where the information is provided and chooses not to be the one to make the choice, it's probably not so clear that it should be dinged as being a failure. So then you would say, well, what kind of measure are you looking for then, Pete? Like, like you don't want to measure their knowledge. You want to see whether they want the knowledge. It gets more complicated. And so again, gets us to these questions about what is a good decision. That's not a full answer to your question, but let's do an online one. Unless somebody else here, a burning question in the room, just so we can throw the phone block around. Oh, Elizabeth's throwing it to Caleb. No.
I'm giving it.
Oh, he's using it for him.
Okay, so we have an online question. It says, how can you ever judge a decision as bad when we can never know what outcome the opposite decision would have brought about? And that's from Heather Penwell.
Who asked that, did you say?
Heather Penwell?
Okay, great question. Right. So the unbearable lightness of being, right, says we don't know the value of anything we do because we don't know what would have happened if we'd done the other thing. We just don't know. So I respect what you're saying. If somebody decides to not get screened and they come down with cancer, we say, oh, that was a horrible choice. They should have been screened. But it turns out if you did go back in time and did the other decision, which we never get to do, we see that the screening test actually would have missed the cancer. Or maybe the screening test would have led to its own problems and this person would have still died of cancer. Like, how do we know what's a good decision? Well, this is partly why we don't look just at outcomes, right? Because it's not actually about which decision ends up with some outcome. And this gets back to Colin's question a little bit about what outcomes matter. Bad decisions can have good outcomes. My favorite example of that is the wonderful and underappreciated movie Bowfinger, where Eddie Murphy on a dare closes his eyes and runs across a highway. It's actually not a dare. He's coerced into it. Horrible decision. The worst decision in the world. Unjust, incredibly dangerous, horrible. The outcome is fine, right? He actually survives it. It's a movie, but he actually survives it and gets the job. I think it was for an acting job he was doing it for. Like, so you might say, well, okay, like pretty good decision, Eddie Murphy or the character he's playing. No, horrible decision anyway, right? We look at the features and the factors before to identify whether people are making good choices. It's not just about whether it works out. You might feel that way later, like, boy, that worked out. I'm happy about it. I would call that a different notion of goodness, of it being a good choice. Like, good thing I closed my eyes and ran across that highway. I got the job. My acting career was made. In some sense, sure, you won. In other sense, that's a horrible choice. More.
I have a question. On slide 14, you have a slide that says continuum of decisions.
Love it. I love slide 14. I almost took it out. I'm so glad you're bringing it up. Go on. I know slide 14. That's this one, right? Yeah.
So when you were talking about the relationship between medical
I have a
uncertainty,
poster of this graph in my room. No, but I'm going to put it up there. Go ahead, man.
when you were talking about the relationship between medical uncertainty and the treatment risk level, I had two thoughts. The first of which is that it seems like a high risk decision where there's one clear best choice might still have high uncertainty if depending on the patient's values. And so it seems to me like we might be passing the buck on the importance of the decision to the patient in higher risk situations to avoid personal responsibility for that decision.
Okay, fair point, right? So you could have so you're thinking of high risk level with where we think there's one best choice. So it's up in the upper left corner there. It's over here. And so it's not in the zone of decision making. So what to say about that? Let me tell you a story.
I love stories.
It's a long story. No, it's a short story. So an executive, a young business executive, walked into the Eskenazi emergency room with chest pain, and the intern was running the usual tests and things, and said, "By the way, if your heart does stop, we want to know if you want CPR or not." It's a perfectly healthy guy, young, just had some chest pain. And the guy went like, "What are you talking about? Am I dying? Like, what's going on?" And when you think about that question, it's a fair question. He's kind of asking the question in that zone. He's like, "We know what we want to do. You're a young man with chest pain. We're going to check you out. And we have to know what to do in case you have a heart attack, your heart stops." But on the other hand, it's a very bad question because we kind of know what this person wants. Unless they come in saying, "I hate healthcare. I'm ready to die even though I'm young and healthy." Unless he starts flagging all of that, it's almost inappropriate to ask, like to see whether he has some, I would call them unusual, I'd say weird values. And so it's almost a mistake to sort of explore that realm with him, unless you have all the time in the world, you have a way of presenting it that won't be very scary, and you have a real reason to worry that maybe he has some strange values. Like you said, the values that would, now I know I put up COVID vaccine sort of as a joke in the case of effective decision making, because that's maybe one where we actually think there's more of a debate, right? Just the way our society is standing right now. And I'm thinking of the COVID vaccine in 2021, not right now. Obviously some people felt that even though medical professionals and we believe that the data was very good, they didn't want it. And so maybe they're in that realm too. They see it as something which is risky, and we should respect that and give them the chance to say no, of course. I wouldn't say this is a graph of whether to ask patients anything. It's more a graph about the importance of exploring their values. And I agree with you, it may always be important, but in cases where there are a range of well-known common values that may make an impact on a high-risk, medically uncertain choice, then that's really where we have to be focusing our attention. Not to say we shouldn't focus it anywhere else. It's a roundabout way to answer your question, though, I think.
Another way of putting it is like that is
Speak to the phone block.
oh there's multiple.
Oh, it's right.
Another way of I guess answering that is like that is the distinction between informed decision making and shared decision making. That on that top category where the treatment risk level is very high, whether or not you have one choice or multiple choices, the threshold for being informed would need to be much higher, which is what I think you're sort of getting at, which is I think what Simon Whitney effectively argued in this paper, right? So it's a important thing, and I think that distinction falls apart clinically often, but I think it does also point to the fact that we do a very poor job of defining when something is preference sensitive and knowing when shared decision making is the most important. Not that you can't do it when it's not preference sensitive, but you see this like general trend towards more and more things are preference sensitive. And sometimes that is because our evidence is not as good as we thought it was, and we're actually acknowledging the uncertainty in a lot of our recommendations. But you see that more and more, and I think that's actually one of the really important messages here is that it's like not done all the time. And when we find the instances in which it's really important, it gets even harder to sort of know if we're doing it well or not. And by the way, no one does well on the option 5 scale. You can look at all the papers. They all look terrible. It seems like it's never being done.
And the option 5, they get poor scores always.
Literally every one. Yep.
Again, this is kind of the funny, hard thing is that, the claim by many, fair claim, not dumb, it's just, I think, simple-minded. Is that taking back a criticism? No, I call them simple-minded, not dumb. Is to say that because this model of extensive discussion is not happening, these must be bad choices. And that I think is not right. I think that, again, as Carl Schneider, I think was very good at arguing, some people may choose to not have that discussion. And as long as it's an option, it's available, maybe that they know it's available, but they choose not to have it, that probably needs a lot of credit for making progress and actually maybe even achieving exactly what bioethics has been trying to achieve since its modern inception, right? If we got to that stage where people could choose how much involvement they wanted and choose how much guidance they wanted, I think we'd be there, even if the option 5 scale was not registering success. So I think that's a good thing to point out, Josh. Other comments, or are we done? Online, this is your chance. Nick.
Currently are not any more online questions, but I have a follow-up question if no one else here does.
Oh, thank you. Yeah.
Well, I was going to ask, are you making an argument for a mixed methods approach to understanding decision making, really in any intervention, basically showing that we need these quantitative measures, we need our qualitative measures, and we therefore need to triangulate decision quality using mixed methods approaches, and that might be actually the only way.
Yeah. No, that's a fair proposal. I think mixed methods and kind of is exactly right. You can use the numbers, but you've got to then look back at them. The second part is that final point about, worry about the injustice. Make sure you make the case before you do a research study trying to improve decision-making that this is a case where there's something really disturbing about what's happening here, maybe in terms of what interventions are being done, in terms of people's understanding. You can probably pull on one of the measures, but you should have a bigger global picture of why this is a problem beyond just, the option 5 scale was registering very low. It requires a more complex evaluation, again, as in all areas of quality, right, where there's going to be no good measure. So I guess what I'd say is yes, mixed methods, but actually I think the deeper question of what it even means for there to be a good decision made is an open question and one which is never going to be solved. So be aware of that kind of problem. And if you're going to focus your efforts, probably focus on areas where you think is the biggest problems. For example, in healthcare, prostate cancer screening, is one area you might argue for. I think colon cancer is one too, where people were not being offered both choices or the option to think about both choices. And we've been working on that one. Prostate cancer screening is a great one too, because so many men were being defaulted with no discussion to being screened. I have no problem with being screened. Good choice for many people, but certainly not a good choice if you don't know there's a good case to be made for no screening. And, that continued or the lessened set of concerns about the provision of healthcare is one that I think should attract attention to decision makers because it's about the quality of healthcare provided. Now, of course, you say, Peter, you just now relied on the word quality again, and you're right. Nick, you get the last question. Thank you, Josh, for that question. Thank you all for your questions.
So following up on my previous question, when is it appropriate to begin discussions with a patient on shared decision making? Like, what are there specific criteria that you can look for? Are there like case specific information? What are the? Because I think Josh said that it's very difficult to know when it's important to involve shared decision making. So how can you, I guess, standardize that decision making process, or can you even do that?
Let's go back to the graph. But there's no answer to your question. It's a wonderful question. Let me wrap up with another quote. So the graph I was going to say is half joke. It's as you get into higher levels of risk and higher levels of medical uncertainty, certainly it's time to start thinking about at least offering people and making it possible people make choices for themselves. Absolutely. So maybe that's a short answer. In the Jay Katz book, which I showed the cover of earlier, and maybe we'll make this available on the webpage when we put up the recording. One of the most beautiful quotes in there is Jay Katz. He says, well, what we call for in shared decision-making is understanding, right? That the patient is understood by the provider and their wishes, maybe about the nature of decision-making, but also about their goals in life are understood and shared. There's a communication there. And so that's our goal. He said, but then how are you doing in your personal relationships at that goal, right? Much less with your doctor. Like, does your loved one understand your dreams and hopes in a good way, or is it not so? Like, if we hope for it in medical care and 15-minute visits with your doctor, how's it going in your home? Okay, that's one. And then, and this is the kicker for me, and I can finish the talk on this, how are you doing with yourself, right? Do you understand your own goals? Do you understand your own wishes? Do you know what you want out of life? Oh, how's that going, Pete? And I'd sit there trembling as I'm reading the book going, not well, I don't know what I want. So anyway, that's a final depressing end to this topic. But thank you all for being here, and thanks for coming.